Okay, so when we're talking about abdominal emergencies, talking about the abdomen, just be aware that, remember, we divided up into 4 quadrants, left, right, and then upper and lower. And what's the point that, like, is the center of everything? Belly button. Yeah, so you've got your line drawn horizontally across your belly button and your line drawn vertically across your belly button. And you're talking about your abdomen right here and the organs that are in there. Because there's so many organs packed into that space, and a lot of them are involved in multiple systems, and there's multiple systems going on, there's a lot that you can be confused by. It's not very easy to determine a specific abdominal emergency out in the field, but that's really okay, because generally speaking for you guys on the ambulance, you're going to treat them all more or less the same way when you're dealing with these emergencies. Okay, so like I was saying, the abdomen is between the diaphragm, which is that big muscle that kind of runs along the bottom edge of your ribs, and your pelvis. In the organs that are there, we're talking about digestive organs, reproductive organs, organs in your endocrine system, and your regulatory systems as well. So, let's see. I know with some of the classes we did this last year. Do y'all remember what's where on your abdomen?
I like the liver.
Okay, so start with the liver. Where's that one?
You're right.
Upper right. Yeah, so remember, left and right is for the patient's left and right, not yours if you're facing them. So my right, upper right over here, this is where my liver is. And it kind of, you can see in the picture, it kind of extends all the way across. On the right side, it covers down and it goes over a little bit too, but we mostly talk about it being in the upper right quadrant. Talk about upper left quadrant, the stomach is over there, and you also talk about the spleen being over there, kind of tucked underneath the stomach. Gallbladder is tucked underneath the liver, so upper left, stomach and spleen, upper right, liver and gallbladder. Going down here to lower right, what's down there? Yeah, specifically your colon. Well, actually, it's not showing on here what I want it to be showing. 1 second. Okay, doesn't show it at all. Appendix is what you should be aware of is down over here. Okay, lower right-sided pain is appendix pain, very specifically. And then your intestines are all in there, and your colon especially is over on the bottom left side. So those are the specific ones to remember. Stomach, spleen, liver, gallbladder, appendix, and colon. Because the rest of everything is filled up by your small intestine and large intestine. The organs are covered by the peritoneum, which is the thin membrane that lines each organ, as well as the abdominal cavity, just kind of basically to help, because stuff moves inside your body, so it gives that extra layer of lubrication to make sure nothing is rubbing and hurting each other, I suppose. You've got the same sort of peritoneum type membranes in your chest, one covering your lungs, one covering the inside of your chest, again, so when they rub when you breathe, you don't get hurt. You've got the parietal peritoneum, which lines the abdominal cavity itself, like the inner walls of your body, and the visceral peritoneum covers each individual organ. So most of these organs are within the parietal peritoneum. There's a few that don't. The kidneys specifically are kind of tucked into the back wall of your body, like right behind the muscles, right near the spine, kind of. They're not floating, but you know what I mean? They're not out in the middle with everything else. The pancreas and part of the aorta kind of also lie in that. It's called the retroperitoneal space. Retro meaning that it's behind. So it's behind the main peritoneal space that all the other organs are inside. Also, the bladder and part of the rectum are below, inferior to the peritoneum. They're not within that main peritoneal space. We just talked about this. The abdomen is divided into quadrants: right upper, right lower, and left lower. The epigastric region, specifically, we're talking about digestive systems. So if we say epigastric sounds, what are we going to be listening for? Or what organ are we listening on? Stomach. Epigastric sounds are found in the stomach, which means when you're listening, where are you going to put that stethoscope? Yeah, up. Upper is the main point. Definitely kind of left upper, but you just don't want to be going down here for epigastric sounds, because these are going to be bowel sounds that you hear down this slope towards where your belly button is. it's a lot higher. Your stomach is a lot higher up than you think it is. Okay, so you've got a patient who is experiencing pain in their abdomen. What we say, visceral pain, obviously would originate from the visceral peritoneum, the part that's covering all the organs. There's not a ton of nerve endings around the organs themselves, so you're not going to get really sharp, specific pain points. They're not going to say it hurts right here kind of thing if it's a visceral pain. It's more of a dull, achy sensation. It's overall, but it's not as precise. You may have kind of a persistent or a constant pain from your solid organs. I didn't mention it specifically earlier, but certain organs in your abdomen are solid and certain ones are hollow. So the hollow ones would be, throw some at me. Stomach. Intestines. What about some of the solid ones? Liver. Kidneys. Yeah. Okay. So more of a constant pain is going to come from those solid organs if it's coming from the organs themselves. What they call colic pain, which is more intermittent, meaning that it's not there constantly, it's going to happen more with the hollow organs, like stomach, things like that, bladder, things like that. So that was visceral pain. When we're talking about parietal pain, we're talking about pain that comes from the parietal peritoneum side. There's a lot more nerve endings here. It's on the inner walls of your abdomen. The pain is going to be a lot more specific. It's going to be a whole lot more sharp, very localized to a specific point. So it'll be easy for them to say, right here, this is exactly where it hurts, kind of thing. Referred pain. That is what we talk about when we talk about how sometimes people have heart attacks and they feel it in their arm, their back, whatever. Referred pain just basically refers to feeling a pain in a location that is not where the problem actually is existing. Because of the way the nerves interact in the body, there's a lot of nerves that end up in the abdominal area or are connected through the abdominal area. They all kind of overlap. And so the pain doesn't go specifically straight down one pathway. It can kind of get a little bit muddled as it comes up. So an example of that is if your liver is having problems, you're going to feel something up here in your shoulder. Or you perhaps will. Because of that referred pain, it's not necessarily going to feel it right where the liver is. It's going to be more of an achy sensation that's going to maybe exist up here in your shoulder. That's referred pain. If you've got some tearing pain, or if a patient is reporting a tearing kind of sensation, this is usually having to do with the aorta. They might be having an aortic aneurysm. Y'all remember what an aneurysm is? Actually, an aneurysm is where a place in the blood vessel is weak. The walls of the blood vessel are weak and they become more dilated. So it's like if it was a normal blood vessel and then there's like a kind of a balloon in the center of it, essentially, where the walls are just allowing it to expand. And because the walls of the blood vessel are weaker, some people just live with them and exist with aneurysms in their body, but they can also burst if they come under too much pressure. And then it's a lot of internal bleeding. So a common source of tearing pain in the abdomen, semi-common, would be an aortic aneurysm that has burst. Because they feel that tearing sensation, and then they're going to be bleeding out really fast. Because all that blood's coming from their aorta, which has just come from their heart. So it's a lot of blood pumping, and it's pumping really rapidly and very strong all the way out into their abdominal area. Talking about referred pain, the location of the aorta, I was saying it's kind of in that retroperitoneal space, right next to the spine, but behind the overall organ area, is going to cause that pain to be felt in the back. They're going to feel kind of a sharp tearing sensation around their back here. Appendicitis. So remember, appendix, right lower quadrant down here. Specifically, if they're feeling that pain, it's more likely than not having to come from their appendix. Signs and symptoms include that pain. Also specifically pain that, I believe they call it rebound pain. I don't remember the exact name, but basically it doesn't hurt when you're pressing down, but as you let go and as the skin kind of rebounds back up, that's when they're going to feel the sharpest pains. That's a very specific sign of appendicitis or appendix problems. Appendicitis is the infection of the appendix. I can say that specifically. Peritonitis is an infection of the peritoneum, which are those layers that are surrounding the organs, as well as lining the interior of the abdomen. It's usually caused by some sort of foreign material that's in there. So if people are have some sort of bladder rupture or something like that inside where, I mean, certain fluids in your body are not meant to get out and touch all your organs. So something going on with your stomach where your stomach acids or something like that have entered the space, where urine has entered the space, those are all really bad because the organs in your body just aren't meant to deal with those fluids. It's very sensitive to acidic substances. So you're going to see abdominal pain and rigidity in your patient. They're going to report a lot of pain. It's very uncomfortable. And because of this irritation in the peritoneum, it causes an involuntary contraction of the abdominal muscles, and that's why it's going to feel really rigid. So normally when you're checking a patient, you're checking to see if it's like soft and non-tender. It's not going to be soft. It's going to be much more firm, like just much more firm, because their muscles are contracting and they almost can't help it. That's a good sign that something is going on with the peritoneum. Cholecystitis is an inflammation of the gallbladder. These can be caused by gallstones. It's real sharp right upper quadrant pain, which again, gallbladder is right behind the liver up here in the right upper quadrant, or epigastric pain, and it also will refer up to the shoulder because of how the nerves work. Pancreatitis is inflammation of the pancreas, which is, again, kind of behind the stomach. That one will refer back up towards the back or, again, up to the shoulder. You're going to see a lot of that abdominal pain refers upwards. It's very common, pancreatitis is very common with chronic alcohol abuse. It can have other causes as well. Gastrointestinal bleeding, or you might hear it called a GI bleed. Bleeding within the lumen, or like the interior of the GI tract. It can be minor, it can be severe, and it can present in a few different ways. So it's either going to come up or it's going to go down. If it comes up, it's usually going to be, well, it'll either be bright red, which is indicative of like a fast, more acute pain or more acute bleed, or it will be really dark, like coffee grounds kind of bleeding that you're seeing coming out. And that's more a sign of like a long, like slow bleed that's been going on for a while. They're both bad, but there's just two different ways it's going to look. If it comes out the other direction, out the rectum, you're going to probably see, again, either bright blood or really dark blood, but that's more a sign of bleeding in the intestine. So GI bleeds can go all the way anywhere up and down, but the stomach is kind of the dividing line. That's whether it comes up or it goes down. They usually don't actually hurt that much, especially if they're more like the slow chronic kind. When I was talking about coffee grounds, I mean like it's like basically dried blood or oxidized blood that is like going through your system versus a fast red bleed. If your patient has gastric ulcers, which are holes in the GI system, that's where some of that acid or those stomach juices can escape and cause the peritonitis. And that would also, you'd see both the peritonitis and you'd see some of that GI bleeding because of kind of the ulcers eating through a little bit of the flesh. Signs and symptoms, so I was talking about this. If it comes out the rectum, you're often going to see either dark-colored stool, which is, they call it melena, is specifically the word for that really dark color that comes out, or it'll just be like red, like regular bleeding. Likewise, if they're vomiting, it can come out as kind of the coffee grounds, or it can come out as just regular red blood. What it comes out as will help give you an idea of what's actually going on inside. Okay, this is what I was talking about, abdominal aortic aneurysm. So the aneurysm is when you've got that weak point in the walls of the aorta. Eventually, the layers of the aorta will start to separate from each other. That weak space gets weaker, begins to bulge out more, and eventually it may actually rupture and break inside the person. So pretty much you're going to feel a lot of pain. The patient is going to feel a lot of pain. That tearing sensation in the abdomen, frequently referring to the back or radiating to the back. And what you may actually see in their abdomen, if you were to pull their shirt up, you're going to see kind of a pulsating mass because that aorta is carrying so much blood immediately right from the heart. You may actually see a little bit of like expansion with each heartbeat coming through from the front. Excuse me. If the pain suddenly gets worse, really fast, really severe, it's more likely than not an actual rupture. So you're looking at massive internal bleeding. You're probably going to have your patient very quickly go into shock because they're losing so much blood. And more often than not, or it's very likely that they're going to actually bleed out. I mean, it's internal, but it's just as bad because the blood's no longer circulating. It's pooling in their body, and with how much blood is being lost, it's very, very difficult to stop that from becoming fatal. Hernia. Does anyone know anyone who's had a hernia before? They're actually not that uncommon. Okay.
Yes.
Yeah. Hernias are holes in the abdominal wall, allowing tissue or organs to come out from where they're supposed to be. So, like I said, this can be kind of common. It'll often happen with like exertion or heavy lifting. Just if the abdominal walls aren't really quite as strong as they should be, this can take place. It can be very dangerous because it is like a loop of intestine, usually, popping out of where it's supposed to be. What you have to be careful of with these is that you don't want to put any extra pressure on that herniated area. You want to make sure that hopefully you get them to the hospital as quickly as possible because they're having a lot of pressure on the space. I mean, it's like a little balloon that's popped out. Okay, there's a lot of pressure on the hole that it pops out of. It's going to cause what they call strangulation of that area. If it's in the bowels, it may be causing bowel obstruction because it's essentially like a clot in the middle of it and it won't move. They often require some sort of surgery to fully repair them. So if somebody has a hernia, they're probably going to report a sudden onset of pain, again, often after exertion or something like that. And you're actually going to be able to feel it. It's some sort of, they call it, there'll be like a palpable, meaning like a touchable mass or a lump or something like that you can feel from the outside. Renal colic, severe pain caused by kidney stones traveling down the ureter. Signs and symptoms of somebody who has kidney stones, severe cramping pain, kind of all back here. You know, the kidneys are essentially right back here, like right underneath your rib cage on your back. So they're going to be feeling pain from there all the way down. They'll often also feel pain in the groin area, and they'll usually be nauseous and potentially vomiting as well. Okay, so people who are having a cardiac issue, often the pain that is associated with that can produce abdominal issues as well. Nausea, vomiting, indigestion, pain in the stomach, all that referred pain that we talked about moving around. So if somebody is reporting that their stomach is really hurting, they've been nauseous and vomiting for the past couple days, just be aware that since that is possibly a sign of a cardiac issue, you want to check their heart as well. You don't want to only assume, talking about that difference between chief complaint and what's actually wrong. Their chief complaint's their stomach, but don't just assume that that's the only thing that's wrong with them. There may be a heart issue as well. So in general, there's a lot of potential causes for abdominal pain. It's not your job to diagnose what is what. Basically, it's your job to assess your patient, sample questions, OPQRST, do your physical exam on your patient, check as much as you can, try to find out as much information as possible, identify anything serious, life-threatening. It's okay to put down what you think it might be based on what you're seeing, but at the end of the day, you're not actually the one doing the diagnosis. Primary assessment is pretty much basic. One note, all patients with abdominal pain should be given oxygen immediately, just because of the possibility of the cardiac issue, and pain in general. You know, it hurts. Oxygen can help potentially release some of that pain, and it's good to give any patient oxygen. Talking about your OPQRST, remember, O is onset, so when did it begin? These are some of the questions you want to ask. What were you doing when it started? P is provocation. It can also be palliation. Provocation is what makes it worse. Palliation is just what makes it better. So ask them, what makes it better? Does anything make it better? Does anything make it worse? Anything that they can do or that you can do? Q, talking about quality of the pain. Ask them to describe it. Try not to feed them words if at all possible. Try not to say, is it a dull pain? Is it a whatever pain? Just ask them to describe it in their own words. You're going to get a better overall assessment of how they're really feeling than if they just kind of latch onto the words you give them. R is radiation. So point to where it is. Ask them to point to where it is. Ask them if it's moving at all, radiating from one section to another, if they feel it in different areas on their body. Severity is pain, severity, or S is severity. How bad is the pain on a scale of 1 to 10? And then T is basically how does it change over time? So is it constant pain? Has it changed over time? Is it intermittent? That sort of thing. If it's a female patient, you want to specifically ask questions relating to their menstrual cycle, because abdominal area, there's all the reproductive organs down there. There's a chance it might have something to do with that. Ask them where in their cycle they are, if their period's late. If they are, if they seem uncomfortable, try to, if you're a male, try to have a female ask some of these questions. If your patient is underage or potentially around people that they might be uncomfortable answering these questions around, try to get them isolated, try to get them comfortable. The average 16-year-old girl is not going to want to answer these questions around her dad. So ask if it's possible, if they're pregnant, are they using birth control? Anything like that will help you maybe diagnose or understand better, not diagnose, where this pain is originating from. Sample questions. You guys know what these are. I don't need to go over them. Specifically, if you're dealing with geriatric patients, be aware that they don't sense pain quite the same way. It's generally going to sense less pain overall. At the same time, they may feel less pain, but they may have a more severe issue, more likely to be life-threatening, and they may have a lot of other stuff going on. It's usually not one thing goes wrong in an elderly patient. It's usually multiple things that are all kind of going wrong together. So they may have a lot of medications. They may have a lot of issues. You want to try to understand what each of those are as best as possible, to really try to get a good assessment so the doctors or whoever else is helping you out will have as much understanding as they can. Physical exam, specifically having to do with the abdomen, you really want to check very well, palpate the area, use your fingertips for this. It says painful area last, meaning you've got 4 quadrants in the abdomen. If they say that their pain is specifically down here in the lower left part, start at the opposite end. Start right upper and slowly work your way down towards wherever they say the pain is. If you start where the pain is, you're more likely than not going to get a response of, ow, don't touch me again, because that hurts them. So start where it's a little bit more comfortable and then work towards the more uncomfortable area. Be aware that there may be rigidity from internal bleeding, also from guarding, which is what we call it when they're contracting their muscles and tensing up. So try to get them to relax those so you can really see what's going, or you can feel what's going on underneath the muscles. When you're looking at the area, you're going to be looking for distension. You're going to be looking for discoloration, for protrusions, which might be what's happening if it's a hernia, like we talked about. For that pulsating mass, if it's an aortic aneurysm, you just want to look at the area and see what you find. Vital signs. As always, take these vital signs, get your baseline, and then take them every 5 minutes or so. The main things that you can do to actually care for your patient: give them oxygen, keep their airway open, be prepared to suction, because a lot of this abdominal pain comes along with nausea and vomiting, and so in case they do vomit, you want to be prepared to deal with that as best as possible. Put them in a position of comfort, transport them as soon as you can. Any questions on this one? Abdominal emergencies?